This is our initial consultation. Just kind of start from scratch and tell me your history and stuff, or do you want me to just kind of go through your X-ray with you?
Yeah, let's do both.
Okay.
Let's do both, and then just a few other questions, which we'll probably go over them. I just want to make sure we talk about.
Yeah.
But okay, so long story short, I've had like breathing problems my whole life.
Yeah.
Essentially, I remember when I was like 7 or 8 years old, I went to a dentist, and he made a comment to my mom. He said like, "Oh, your son's roof is really high." And I don't know if it had to do with like sucking on the thumb or I don't like all those different things that might result in that. My mom never really did anything about it. I guess, my parents just didn't know. They didn't think to do it, and it's probably common.
Very common.
Yeah.
You're lucky you even found a dentist that noticed that.
Yeah.
Let me just tell you that in itself is pretty unusual. Back then and even nowadays. So
I would assume so. Yeah, this is a long time ago.
Yeah.
We're talking like 20 plus years ago.
Yeah.
So so I struggled breathing, a lot of issues with sinuses. Anytime there's a switch in seasons, especially into spring, I'm the one that's
congested right away.
Congested,
Yeah.
I'm sneezing, struggled a lot. Super allergic to cats. I don't know if that's related, but I struggled. I mean, I'm very athletic and I love doing sports, but I have a very difficult time doing like endurance or like cardio. Like I can't run. I
just feel like it's hard to breathe?
Yeah. Yeah, and like my nose gets obstructed, and many times, like even today, if I'm on the treadmill, and I try to breathe through my nose, and like I purposely like seal my mouth. My nose starts running, which I don't know doesn't seem like a natural thing. But in any case, when I was like 22, I thought, okay, maybe it has to do with my septum, which is deviated, and it still is deviated. Which you can probably see from the scans.
Yeah, we'll take a look at that in a second.
So I did a surgery to straighten the septum, and also that doctor, he cut my turbinates, and you'll probably see in the scan, like essentially my left side, like there's almost no turbinates left.
Gotcha. So he did a complete turbinectomy on you.
Pretty much, and obviously that's not ideal, but that didn't help me. So I still struggle breathing through my nose. I don't have anything like the empty nose syndrome, for example. I haven't experienced that, thankfully, exactly. But my nose is still kind of like this, and the left side is where the turbinates were taken out, but I still have like an obstruction. So I've been doing a lot of research. I read the book by, I think it's like James Nestor about breathing, and that put me down a path on figuring out what's going on. Then I did the Invisalign as a first way to maybe resolve things, but Invisalign can only do so much. It only adjusts the teeth. At some point, I can't bend the teeth outwards. There's something more structurally necessary to be done, and that's when I just kept on digging deeper and deeper. And then how I came across you and then the Breathing Institute. And I know that there are a bunch of different types of these surgeries. Like there's like the Lefort, which is I think a little more invasive. But long story short, I'm here to do the surgery to, one, breathe properly, kind of figure out, what's going on, because I don't want to do another deviated septum surgery. Also, as part of that, fix a bunch of other things, which you can probably talk about, such as like forward head posture, which I know is that's a compensatory mechanism to open up the airways. Yeah. I have all these issues, so...
I was actually about to measure your head positioning.
Yeah, so if you can... so I'll let you take it from there.
So that's a beautiful history. Obviously, I can tell you're more well knowledgeable about this than most patients. Very common history, unfortunately. A lot of people have had the same history of you. Even people that get like diagnosed young and have palatal expanders, there's a lot of them that either relapse or they weren't expanded enough, and they, even in adulthood, have to get re-expanded. So
I have a cousin that did an expansion, and then my aunt was telling me, don't do this surgery. Your younger cousin did this, it's not going to help you. So maybe you can tell me more about that.
Yeah, there's, it's hard to say, because at the end of the day, this is like a multi-dimensional issue, all right? And what I mean by that is that just looking at your airway and your nasal breathing and stuff, there's so many different dimensions to it. Number one is going to be like skeletal stuff. Yeah. How wide is the nasal cavity? How wide is your palate? Those kind of skeletal components are very, very important. There's soft tissue components. Sometimes they can be think that's like the second dimension, for example, deviated septum, right? Or, you know, inflamed turbinates or whatever. There's soft tissue components that are also variables. There's a functional component to it, right? Like, do you learn how to breathe through your nose? So doing breath work, tongue positioning to make sure your tongue's sitting against the palate, the roof of the mouth, and you're breathing through your nose, is the third dimension. The fourth dimension is actually what you brought up, which is the compensations that develop and trying to undo those. And I make that the fourth dimension because it's time. You know, in physics, the fourth dimension is time. The compensations develop over time, and then trying to reverse that is, I think, an important fourth dimension to treat.
Yeah.
Long story short, to answer what you were talking about, I think what happens probably in a lot of children that get expanded, taking away, maybe they're being underexpanded, I don't know because I'm not there, is you expand them, but then they don't learn to breathe through their nose. They don't practice breathing through their nose. They don't practice keeping their tongue on the roof of their mouth where it's supposed to be, and then they're going to continue to relapse as they grow old. Right? So that's my personal theory into all of that. So looking at your case, you want to start by going, oh, we didn't talk about your sleep. How's your sleep?
Oh, so that's another thing I did. So when I did the Invisalign, and I did with the doctor, this was in San Francisco, by the way, and I only recently came back to Southern California. So part of that whole thing, she made me do a sleep study. So they gave me something to take home, and then for 1 or 2 nights, I was using that to kind of like test the quality of my sleep. And I did have sleep apnea. There was like, it wasn't severe, but also it wasn't like minor. It was recognizable sleep apnea.
Yeah, like mild to moderate or something.
Yeah, I don't remember the exact details, but I mean that also. So what I started doing is actually taping my mouth when I go to sleep. Because before I would do that, the quality of my sleep was low, and I would find myself really like during the day, just sleepy, having to take naps. Ever since I've been just taping my mouth, I don't need naps anymore.
Yeah.
So that already kind of...
Pretty remarkable.
It is. It's crazy.
It's good that you tolerate it, because some patients, before expansion, when they do have a narrow nasal cavity and stuff, it sometimes can be hard to tolerate mouth taping. But mouth taping is an amazing tool at retraining the brain. You know, undoing some of those nighttime mouth breathing phenomenons that happen, because, you know, retraining the brain is hard. You know, I like to equate it to learning the piano when you're 40 years old, when you didn't grow up playing the piano. It's like, can you learn? Yes. It's pretty hard, right? It takes lots of practice to reprogram those neuromuscular circuits in the brain to be able to do that. It's the same thing when you're trying to switch from being a nighttime mouth breather to a nighttime nasal breather. It can take months, like a year sometimes, of like dedication, mouth taping, oral myofunctional therapy during the day, all that stuff. It can take months and months, and people get discouraged because, you know, they practice for a couple of days and that guy still mouth breathe. It's because you got to rework those circuits. So you have some sleep apnea. It sounds like symptomatically you feel a lot improved since mouth taping, which is great. Now, do you have trouble falling asleep at night?
No.
No trouble staying asleep at night?
Quality of sleep is
very good. You wake up refreshed?
Relatively, yeah.
Good.
I would say I feel pretty good.
Good.
When I wake up, also I kind of benefit from just breathing through my nose for a few hours before it gets stuck again.
Yeah. Okay. Very good. That's a great history. Thank you for that. Great. So do you want to get into your CT scan? You can show the world?
Yeah, let's do it.
All right. So this is a CBCT. It's a 3D X-ray. This is of your maxillofacial region, which is basically your head and neck. All right. So you can see, we can look at your full facial development. First thing we're going to look at is your airway. So this is actually not your nasal airway, but this is going to be your airway space. So this is the airway behind the upper and lower jaw that all the air passes through when you breathe. Okay, people that have obstructive sleep apnea, This is the part of the upper airway that obstructs during sleep, which impedes normal airflow, can cause oxygen desaturations, can also affect your sleep quality and architecture and cause arousals and all that stuff. So this is going to be a 3D rendering of that posterior airway space. In the old days, we used to just measure it two-dimensionally, so we would just measure how long the airway is, so we call it the posterior airway space length. So we would just kind of do these kind of length measurements. And we do it at multiple areas, like behind the palate, behind the tongue, behind the mandible. And we would say that anything below 11 millimeters is considered too small. So you're obviously not too bad here. There's one area where you dip below 11 millimeters. Nowadays, this 2D is a little outdated. We can actually create a 3D rendering of that posterior airway space. And that's what you see here. This is a little more accurate because it is a 3D structure. The most important 3D measurement we look at is something called the minimum cross-sectional area. That's where we go slice by slice, level by level through the airway. We measure the area at each slice, kind of like the square footage of a room, but we're measuring in square millimeters. And we're trying to see, is there an area that this constricts? If so, where and how bad does that constriction get? All right. Looking at your airway, you're pretty good. Your minimum cross-sectional area is about 346 millimeters squared. We tend to see sleep apnea more frequently in people below 150 millimeters squared at their most narrow. That being said, there's plenty of people that have sleep apnea that are above 150 millimeters squared. There's plenty of people below 150 millimeters squared that don't have sleep apnea. That's just kind of the area where we start seeing about a 3 to 7-fold increased risk. Now, you're talking about forward head posture.
Sorry, just in terms of that minimum cross section, because in the 2D version you said it's about 10 millimeters. So in the 3-dimensional, where it's like 346, how is that? Is that?
It's considered average to above average.
Okay.
Yeah. Now, I published a paper last year or the year before in the Journal of Oral Maxillofacial Surgery that looks at how a forward head posture can actually alter the size of your airway. So there's a measurement that we came up with called the nasion to basion to the upper anterior point of C3, and yours is actually pretty good. So when you took the scan, you didn't have too much of a forward head posture, but sometimes patients can have an abnormally large airway because each 5-degree change in the nasion-basion to C3 angle can account for a 25% increase in your airway size. And that's why people even develop that compensation, is because that compensation makes your airway bigger.
Yeah.
So at the expense of your spine and shoulder and neck health, you will have a little bit better airway. That's why people develop it. It's subconscious. Your brain is always going to choose breathing and continuing to live over TMJ issues from clenching at night and forward head posture and the spinal issues that develop. Now, I want to analyze how wide your jaw is. Obviously, that's why you're here. There's a few different measurements we do to analyze jaw width. First of all, are you missing any teeth? Looks like you're missing your wisdom teeth. Anything else?
No. But yeah, I did take out the wisdom teeth.
Yeah, so you're just missing your wisdom teeth. Okay, so we come to where the first molars are. So these are your second molars, and then these will be your first molars. And then I'll measure the width of the jawbone, of the upper jawbone, at the first molars, and you're measuring about 55.3 millimeters across. I do the same thing on the mandible at the first molars, and you are about, let's say, 58.3. So right now your mandible is skeletally, just measuring the bone, teeth not included, because as you said, you can get ortho and stuff and they can try to push your teeth out. So I want to just look at skeletally, how did you develop? Your mandible is 3 millimeters wider than your maxilla. It's actually ideal for your maxilla to be 5 millimeters wider than your mandible. So this is actually a delta of 8 millimeters from ideal. So just skeletally, you're deficient about 8 millimeters relatively from where you're supposed to be based on your mandible. All right, then there's the common measurements that people use. There's something called the intermolar width. So because the teeth grow out of the jawbone, we can measure the distance between your teeth and use that as a kind of surrogate to determine if your jaw's grown wide enough. We again measure this at the first molars from the CEJ mesiobuccal, or mesiolingual, excuse me. And you're measuring about 32 millimeters across. 32 millimeter intermolar width is considered a very severe narrowing in an adult male. Ideal adult male measurements are between 38 and 42 millimeters across. So again, you're looking at 6 to 10 millimeter deficiency, kind of going right in line with that 8 millimeter skeletal deficiency that we saw before.
So this is upper jaw, right?
Maxilla. The last, upper jaw is called the maxilla. The last measurement we do is called the nasal aperture. Can't see it great here, but if you look at the skull model, all right, your maxilla is actually the largest bone in your face. It's this pinkish reddish bone here. It makes up a majority of the middle third of your face. It determines how wide your palate is, which is very important for how much space you have in your mouth for your tongue. It will also determine how wide the nasal cavity develops, which really impacts your nasal airway and how easy it is to breathe through your nose. So the next measurement I do is called the nasal aperture, the piriform aperture, where we measure how wide that skeletal opening into the nasal cavity is. For adults, we usually like to see it no less than 23.5. 23.5 is like the smallest that is clinically acceptable. After expansion, people's nasal apertures shoot up to 26, 27, 28 millimeters. Okay. So 23.5 is kind of what we consider the most narrow. And you are about 20.5. So 3 millimeters less than the lowest of the lowest that we would find acceptable. So well below where you're supposed to be.
And I mean, so I saw there's a specific place that you do that measurement? You don't do it from like the largest?
Yeah, you do like a few millimeters up from the floor of the nose. Mm-hmm. So this is kind of the, maybe like 4 or 5 millimeters up from the floor of the nose. Yeah. Yeah, not from like the middle.
Got it.
Yeah, not from up here, but from like down here. Then scrolling through your nasal cavity. Yeah, you're definitely missing your inferior turbinate on the left side. Outside of that, your septum does not look really deviated. You have maybe a little bit of rhinitis. Maybe it looks like the lining on the nose is a little thicker than normal. So maybe you do have a little bit of allergies that are kind of compounding the narrow nasal cavity that you're having. Mm-hmm. And that's making your nasal breathing a little more difficult, kind of having both things going on at the same time. Yeah. What I'll tell you is that one of the most common things we hear from patients is that, allergies are a real thing, right? So things that used to trigger allergies and lead to really bad nasal congestion don't anymore. Because once you have an expanded maxilla, and your nasal cavity opens up like that, even if you do get a little bit of rhinitis and the lining of the nasal mucosa inflames a little bit, there's still so much space in there that it doesn't really cause bad nasal congestion anymore.
Got it.
Does that make sense?
Yeah.
So like patients tell me all the time, like every fall, I used to just, now I'm fine. I don't feel it anymore. Doesn't mean they don't have allergies anymore. It's just the allergies
are not severe.
They're not able to clog up the space anymore enough to cause nasal obstruction because the nasal cavity is so much more enlarged.
Would you say that also because everything is kind of tighter in space, throwing that additional mucus or whatever that causes the irritation, then the nasal cavities they expand even more just because of the irritation? Is that also something, or?
Can you restate that? I'm sorry.
So, for example, let's say the navel cavities, because everything's so close, so they're automatically just more irritated, especially where there's that additional mucus due to the allergies?
Potentially, yeah. I mean, potentially just once you're able to breathe through your nose more, things just clear out easier and you don't get as congested from that as well. Sinus health tends to improve quite a bit after maxillary expansion Obviously, we're not directly treating your sinuses, but as you expand the maxilla, just the natural physiology of the sinuses to the nose tend to improve.
Yeah.
So that's another nice effect. I mean, it seems like the osteomeatal complex, which is what drains your sinuses, function better as you expand the maxilla, as do your eustachian tubes. So a lot of patients who have, problems with like inner ear health, where they're like, they can't pop their ears well, they go on planes and things like that. Once you expand their maxilla, the eustachian tubes function better, and suddenly they don't have those same problems on flights and things like that.
Wow. Okay, that's also something that impacts me. That's critical.
Yeah.
Okay.
So I think you're a great case. I think you're really going to benefit from this.
And the nasal, okay, so and to that nasal I guess, yeah, that makes sense. So the nasal cavity is going to expand, and everything is essentially just going to be much wider.
Your nasal cavity is going to three-dimensionally expand. So all of this, not just down here where I measured, but the entire nasal cavity expands. The type of expansion that I do is called mid-face expansion. So you were talking earlier about seeking me because alternative versions that are being done most in the country are called SARPEs or domes. They're based on what's called the two-piece Lefort-1 osteotomy, which is a bigger surgery. The other downside of it being a more traumatic in-hospital big procedure is that the type of expansion you get is not the best for your airway, because the bone is cut all the way across down here and here, and you expand just at the floor of the nose. Versus the type of expansion you get here is going to be the entire middle facial third. So the entire middle facial third is going to expand, and you're going to get three-dimensional expansion of the entire nasal cavity. That's why it's much more profound in terms of its improvement in nasal breathing compared to a traditional two-piece Lefort-1 osteotomy that is done in a SARPE or dome.
And so let's say for the mine procedure, where exactly would the cuts be in this case?
So I do, there's 3 incisions, all right? There's 1 incision inside your upper lip. It's about 1 inch big, all right? I use that incision to split your palate down the middle. So that'll be from, it actually kind of looks like that. I kind of come between the 2 teeth and I cut all the way back. There's 2 incisions in the back of your mouth. That's where I disjoin the pterygomaxillary junction, so where the maxilla attaches to the pterygoids. That'll allow you to get even anterior to posterior expansion. Otherwise, people tend to get a V-shaped expansion where they expand much more in the front than they do in the back. Ideally, you want to get as parallel, even expansion as you can. Part of that is releasing the pterygoid from the maxilla so the maxilla can expand freely in the back. The last thing I do while I'm in that front splitting the palate is I free the nasal septum from the maxillary crest. So if you look on the scan, this is your nasal septum, and it attaches to the top of the maxilla. So I will actually free the septum from the maxilla so that when you expand, there's no risk of your septum getting deviated. Because what happens in cases sometimes when you don't free the septum from the maxilla is the septum can follow one half of the maxilla, and as you expand, the septum will follow that half and deviate towards that side. So I free the septum to make sure that doesn't happen during the expansion phase of the procedure. And so it's those 3 little incisions that I talked about. They're each about half inch big. 1 in the front, 2 in the back. Free the pterygoids, free the septum, split the palate. During the surgery, I expand people a few millimeters, make sure everything feels nice and loose, and make sure you're not going to run into any issues during expansion. And then at the end of surgery, close you back up, wait for a callus to form, and then you start expanding at home.
Got it.
Yeah.
So if the septum is detached, how does it? Is there like a?
It'll reattach eventually when you stop expanding, and in the beginning there's no bone in the middle of the palate.
Yeah.
So once you're done expanding, we go into something called the consolidation phase, which is where we wait 4 to 6 months for bone to finish filling in that defect that develops during the distraction phase. Once that bone fills in, the septum will reattach to the new bone.
Does that mean I need to be careful when I'm blowing my nose? It has nothing to do with that?
No.
And is the alignment of the, so for example, I guess you said that the septum is not so deviated for me.
No.
But there's not going to be any change in this. Okay, so it's all going to remain.
It's about not causing deviation.